Oh man, yeah, I am so privileged to be able to take care of patients with lung cancer today as of 2026. There was actually just an FDA approval yesterday.
Oh,
Like that's
wow.
how fast things are moving. So like I said, I work with a lot of trainees at my institution, and almost every month they rotate through, and I get to say, "Hey, listen, we have this updated data from this trial, and this led to an FDA approval." It's almost like every month, every other month in lung cancer. So there's absolutely hope. The science is moving incredibly fast. And lung cancer is truly this poster child of personalized medicine, where we're really trying to understand exactly what type of lung cancer the patient has and then matching them to a very targeted, precise regimen of therapy.
Yeah. That's really cool to hear because,
Yeah.
as all of us were coming up, you hear about personalized medicine, but
Yeah.
now you're starting to see some of the actual
Yeah.
implementations of that, especially in the cancer space. So that's really cool.
That's right.
Awesome. We ready to jump into some
Oh, I'm
clips?
Take a look
excited.
at them.
Awesome. Well, this is our first one. I believe this is your clip.
Okay.
Yeah, let's do it.
I was looking for you.
Well, you found me.
The X-ray came back on the lady with the cough. Weird infiltrate. Have you seen it yet?
I've been trying to catch up on my charting.
Right here.
Yep. Stringy right lower lobe.
It looks like aspiration pneumonia. Think about it. How do oral and gastric fluids end up in lungs?
Dysphagia, swallowing disorders, but she's not an old person choking on their food.
Right, and there's protracted vomiting.
Okay, maybe recent gastroenteritis, food poisoning.
Yeah, or an eating disorder.
Think she's bulimic?
I mean, she's fixated on working out. Check the enamel behind her front incisors. If it's not in the differential, it won't be in the diagnosis. You know that? Yeah, you know.
Oh, man. So tell us why you picked this clip.
Honestly, for that last line that Mel just delivered, right? If
Yeah.
it's not in the differential, it won't be in the diagnosis.
Yeah.
You guys are also emergency medicine physicians. I'm internal medicine trained. And so the differential diagnosis is huge for us, right? I remember being pimped by attendings about the differential diagnosis. We'd have to write it beautifully in our internal medicine notes. That's why our rounds take so long as internal medicine residents too, because we love to talk about all the differential diagnoses. And I think that's really important though, right? One, we are very susceptible as just medical physicians to have this anchoring bias, right? Where, you just sort of make your short list and then you just stay in that. And then you don't think about the zebras, right? And potentially the other diagnoses that the patient could truly have. And then it leads to premature closure where you just stop short of immediately thinking beyond an easy diagnosis, if you will. So that's why that really resonated with me is because it takes a lot of vulnerability as well too to put out a diagnosis sometimes, especially to your colleagues, to your peers, to your seniors. And so I really appreciate that she did that.
Yeah.
Yeah, for real, man. Thinking outside the box for sure. I mean, in ER, you never know what you're gonna get. It's always like I call it like you're walking through a landmine with like clown shoes on sometimes. Like you're just waiting to step on something because like you have the weirdest diagnosis, and so we do have the tendency to like anchor on certain things. Everything comes in, chest pain, you're looking for heart attacks, but also be dissection P's. You just gotta make sure you keep your differential wide and keep
Yeah.
expanding on it and work everything up.
Yeah, and we talked about during one of our previous episodes anchoring and
yeah.
how easy it is to do that because you see something and it looks like something
Yeah.
and a few pieces of evidence kind of support that and you're like, okay, case closed. And it's so
Right.
easy to do that, especially when you have a full waiting room or you're rounding and you have 20 other patients to round
Yep.
on. You're like, it'd be easy to just do that, but that's how you miss things and that's how you get bad patient outcomes. And so, to any medical students, residents, anyone listening, I know it can be gruesome at times and tiring and rounds can last forever, but it's very, very important. And it's one of those things where when I was a trainee, obviously everyone's like, oh man, rounds is going to take 6 hours because we're
Yeah.
going to talk about all this stuff. But like now, to be honest, like when I get that, one-off case that's not clear cut and I'm having to like go beyond the PE, ACS kind of thing for chest pain,
Yeah.
I'm like, oh, what else could this be? I find joy in that because like everything else, it's like bread and butter. You're going through it and it is the thing that you think it is in front of you. And so it is sometimes fun to kind of go on those like mysterious like journeys and try to figure some things out.
Yeah, it's not just med students either. It's like even seasons attendings. Like you keep seeing things over and over and over. Like, okay, I've seen this a million times. This is what it is, and you may not, go that deep into it, and you can miss stuff. Especially if you've been out like 10, 15 years. Not everybody reads all the time. I know you read a lot of studies. Sometimes people. I mean, it's a good thing you do because a lot of people like don't keep reading, and you keep seeing this stuff over and over, and you can anchor on one thing as well and miss it.
Yeah.
I'll put in one more plug just personally. So I focus on young onset lung cancer. So the majority of my patients in my clinic are under the age of 50. And this incidence is rising. So right now it's about 10% of patients being diagnosed with lung cancer today are going to be under the age of 50. And it's painful to see these patients being dismissed or having delayed diagnoses because of something like an anchoring bias, right? Oh, you're too young to get lung cancer. You're too young to have cancer. And so I think this really resonated with me as well, too, from that standpoint, just to say we've got to move beyond that anchoring bias. We've got to move beyond that premature closure to give patients really the benefit of the doubt to really understand and work them up if they're having recurrent symptoms, if they're having symptoms that have yet not been diagnosed correctly, right?
Yeah.
Is there a reason for that, you think? More smoking, vaping, hookah, stuff like that?
Yeah, we're trying to learn. So what we've definitely learned is that there are other risk factors beyond that personal smoking history. So radon gas exposure is actually the second most common cause of lung cancer in the United States. Air pollution has been shown and proven now to trigger the development of lung cancer as well. PM 2.5, I know you guys have heard a lot about that as well too. There's rising rates of it. There's also cooking fumes, work exposures, you name it, even some genetic changes as well too. But it's an active area of research that I'm really passionate about.
Yeah, and that's why like in the ER we get like incidental findings, and
Yeah.
a lot of times the incidental findings, you get a chest X-ray and there's like a nodule there or something. You tell people to follow up on it. If you're like a member, just listening right now, like please follow up on it, because you don't want to be at another ER visit in 2 years for something different. They're like, oh, now it's definitely lung cancer.
Yeah.
This it's probably developed over the course of 6 months or a year. And if you'd follow up on that nodule, maybe the situation wouldn't be as bad as it is in that situation.
Sure.
Yeah.
100%, man.
Yeah. Any other thoughts on this clip? What I guess my question for you mentioned rounding. What's like the longest round?
man.
Like during, could be anywhere, med student, resident, fellow, like in the ICU or something. Like
It was definitely ICU rounds,
Yeah.
I think. They just took forever. And where I trained, the intern that was on from overnight was the one that had to present all the patients in the morning.
oh, that's brutal.
And so it was brutal. Like you would be exhausted and you would have to give beautiful presentations, and it depended on the attending that was sort of grilling you a little bit to expand on your differential diagnosis. It's like, man, I just want to go home and sleep.